Hello everyone, thank you for joining this AJMC TV Peer Exchange video program on the innovation and role of alternative markers of efficacy. This program is part of the Oncology Stakeholder Summit series and features key insights from a distinguished panel of experts, each well known in our professional community. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University and an associate director of surgical intensive care at the New York Presbyterian Hospital in New York City. I'm joined today by Dr. Ira M. Klein, National Medical Director, Clinical Thought Leadership, Office of the Chief Medical Officer, Aetna Incorporated, and by Dr. Richard W. Joseph, Assistant Professor, Division of Medical Oncology at the Mayo Clinic in Jacksonville, Florida. Thanks to both of you again for joining me, and why don't we just get started. Now, there is no arguing that early diagnosis and improved treatment measures have had a positive impact on cancer survival, while personalized medicine has helped select the right patient population and target a regimen using biomarkers. Immuno-oncology has revolutionized the treatment approach in advanced solid tumors, harnessing the body's own immune system, something I never even dreamed of when I was a medical student. Maybe I'm just old, but I mean, that's just the way it is. Why don't we begin by discussing how different stakeholders would define the value of such innovative approaches in oncology? And the stakeholders would be what? They would be the providers, the FDA, the payer, the pharmaceutical industry. You want to start on that?
Yeah, I think, Peter, one of the things we have to understand is that when we talk about this, we have to think about each entity's mission. And each entity has a mission that is both clinically pure in trying to move patients to a better outcome, advance the science, but each entity is also tasked with carrying out the mission of their business plan and business entity. And don't forget, all of us today here are part of the medical industrial complex. So
you're paraphrasing Eisenhower.
Yeah, no, I know, but I think the analogy really works because we have a higher goal that I mentioned earlier about patient care and outcomes, but we also have the market-driven goals of each entity, or in the case of the FDA, the regulatory mission. So the easiest entity to talk about is the patient. Certainly, patients are all in when it comes to understanding value, especially now in the era of the Accountable Care Act, where either on purpose or inadvertently, in cancer care, they have their out-of-pocket monies depleted from themselves rather rapidly in cancer care. So patients very much understand value in cancer care because they're paying a lot of those first dollar bills. If we talk about the FDA definitely understands value and has made huge strides in trying to move this science forward with the ability to have breakthrough therapies, have therapies come out earlier with collection of evidence, and yet the FDA still primarily approves drugs based on safety and efficacy. So there's a little bit of a mismatch on the value there because value is something that is on a continuous measurement. Some have more value, some have less. And approval of a drug is a binary function. Either you're approved or you're not approved. There's a little bit of play in that when it comes to breakthrough because that can be pulled away. So on the payer side, the one that I know the best right now, I would say that we are tremendously invested in understanding value. And the way we're deploying that in the marketplace has a lot to do with the legislation that the federal government has brought out in the Accountable Care Act and all of its various ways of working through the system. So that would be integrated delivery systems with the Accountable Care Act. That would be certain aspects that have to do with privacy and communication. And so we're putting together models that really measure value and actually push value basically back onto the providers, which is really where Richard sits. So I think I've addressed a few of those.
You know, by the way, it's not the Accountable Care Act, right? It's the Affordable Care Act.
You're right. Yes,
right.
Sorry. Yeah.
I want to go back to that question about value and just throw a kind of a personal story behind that, which I've got to watch evolve over the last year. And since we're talking a lot about melanoma and immuno-oncology, I'm going to talk about one of the clinical trials that we had with the pembrolizumab that just got FDA approved. And
I'm not going to make you say that 5 times fast.
So what was interesting about this trial is we were a part of the expanded access program, which allowed patients to have the drug for free. of course, their insurance companies would pay for the delivery of the drug, office visits, scans, and labs, but the patient was not charged at all for the drug. So what was interesting, the trial started around April, and the drug got approved in September. So from April to September, you have patients are doing great and no complaints about co-pays or anything like this. And once the drug gets approved, and say patients are doing really well, the question becomes, no one really knows how long to give the drug. Should we give it 6 months? Should we give it a year, 2 years? Nobody really knows. But I think once the patient has some skin in the game too, once the drug is approved and now those co-pays become more relevant, the decision becomes a lot more interesting in how to try to figure out, whereas one patient might say, man, I'm doing great, I can't see any cancer in here, maybe 6 months is enough, should I go another year? And it starts to come down to the individual basis, and there is no right answer, so it's kind of interesting.
If I hear what you're saying, when the patient has no skin in the game, the patient basically says, well, give me more, I like this drug. And when the patient has to have some out-of-pocket expense, then the patient's participating in the calculation, is that right?
Correct. And that's what I think personally, and I'm not a medical economist, but skin in the game for all parties is essential to have the most value-based system.
Well, let me tell you what I hear. I'm not sure this is true, so I'm going to ask you whether, first of all, if you agree with this. But what I hear on the street is that clinical trials in oncology, they're usually conducted in patients who have the worst prognosis and who failed prior therapies, and that this impacts any discussion on value, because these are worst-case scenarios.
Yeah.
A, is the statement true on its face, and does it have an impact if it is?
So the statement, I think, is paradoxically false in a way, because while it is true that the patients in some of these early phase trials have failed the standard of care and are therefore willing to take a risk with an experimental therapy, they really are the healthiest bunch of those people, because what ends up happening is the patients who, there's usually a window of time to get into a trial. You enroll them, you consent them, you might have to get a biopsy. Those things take 28 days. Some patients might crash in that 28 days, so therefore you've already eliminated those patients. Then there's patients who are ineligible for reasons that wouldn't make them ineligible once the drug was FDA approved. Say a prior history of prostate cancer 10 years ago might make someone ineligible for a melanoma trial, whereas we, as an oncologist, that's not going to play any role, but per the trial, that's a exclusion criteria. So in essence, I think the trial population is actually probably a healthier, better population, and sometimes what you see in the results of the trial are maybe even actually a little bit better than what you would see in real life, because you have now in real life included all these exclusions.
If you make that assumption, which you say we shouldn't make, that actually can lead you to some pretty dangerous conclusions, which is if the patient population getting this isn't the worst, but in fact maybe a better population, then the drug may not be as good as you think it is, because these patients might have done better.
One of the issues, though, in drug development and drug utilization has been that typically drugs in the past have been developed and tested for a particular indication, and once that drug is out on the market, then often those indications broaden. And people say, well, it was approved for A, but I want to see how it really works for B, C, D, and E.
Is there a disparity about what the FDA is looking for and the actual value that a therapy can afford a patient? In other words, the FDA is looking for what? It's looking for, is it efficacious, is it safe? But there's far more subtle aspects to drugs, right?
Oh, totally.
So what do we do about that?
Well, I think that the position of only strictly approving on safety and efficacy was a past model, and I believe the FDA is rapidly coming up to speed on the understanding that in the modern world of biologics with much more narrow indications and much more expensive drug therapies, they will have to be more nuanced in their approval process for incremental benefit, and not necessarily always approving drugs with either no incremental benefit or very minimal incremental benefit. So I believe that drugs in a therapeutic category that are considered to be Me Too will have a much higher bar to jump over than they did 5 years ago.
Almost makes you feel sorry for a federal bureaucrat, doesn't it? It's not just yes or no anymore. It's yes, but here's a little shade. Is that fair? Do you see that from the FDA, or have you not seen it yet?
Yeah, I think one thing kind of related a point to what you were bringing up about, off-label use. It's interesting because, if you ask a panel of melanoma experts, and let's go back to pembrolizumab, recently approved in September, its indication is for patients who have failed both ipilimumab as well as a BRAF inhibitor if they have a BRAF mutation. And whereas if you ask, if one of you guys were my patients and had metastatic
By the way,
melanoma,
we would be lucky.
We would be. We would be lucky.
In my medical opinion and expertise and experience, I wouldn't want you to fail those two therapies first, because I do believe the pembrolizumab is the best therapy and would be not only best for you, but actually probably best for the system, because of the patients, most of the patients will probably get a very nice response, therefore nullifying the need for other expensive therapies such as ipilimumab or BRAF inhibitors in the future. So it's kind of interesting how the FDA approved that, because the trial wasn't really based solely upon people who had failed. There were certainly patients who were treatment naive that also had incredible responses. So,
Yeah.
but there will be more data, phase 3 data in the frontline setting. But it's I agree with the off-label use in general. We can't totally broaden it, but if having a little bit of flexibility would be nice.
Yeah, I don't think that's a bad thing. I think that the only issue behind that is the paucity of data.
Well, unless you do the work.